And now, here's a topic that is critical in pharmacy, and this is called additive toxicity. And I'd like to talk about bleeding risk because I work among elderly patients, and most of our patients, of course, are elderly, unless you are working in peds. And so for that reason, we've got to be careful because many of the agents that increase bleeding risk are used in the elderly. And what would that be? Well, of course, you've got aspirin, and then you've got Plavix. I'm writing the brand name because it's shorter. And then you can have the person also taking ginkgo biloba, which is used for memory enhancement. And this product inhibits platelet activating factor, so it's risky, as well as other drugs. NSAIDs, for example, can increase the risk of bleeding, and others. So I'll just put etc. here. And so they're used in combination. Maybe one or two by itself is not a problem. What happens if you have many? This is a big problem because potassium can stop the heart. When some states perform lethal injection to people who are on death row, what's killing the person? A potassium injection. If you take your animal to the vet to have them put down, they're going to inject straight potassium, the heart stops. So we're certainly very concerned with not doing that accidentally to a patient by additive potassium. And this would be like ACE inhibitors, spironolactone, other aldosterone blockers. These are used together, so you got to be really careful about potassium. Salt substitutes, which are KCl. The birth control pills, Yaz and Yasmin, both raise potassium. And normally that's fine, but how is potassium cleared? Potassium is cleared by the kidneys, renally. And if your renal function is reduced, you cannot clear potassium well. So when we see a problem with elevated potassium, it's typically in a patient with reduced renal function taking 1, 2, maybe 3 of these drugs. Now, this is the problem I see most commonly clinically, and that is additive CNS depression. Let me give you an example of a patient that I think we all see on a regular basis. Let's take the patient who is on an opioid agent for pain, and let's put the patient on a skeletal muscle relaxant. Let's put them on Flexeril, very popular drug. Why don't we also put the patient on an NSAID PRM? Let's put the patient on Zolpidem. That's Ambien for sleep. Who can sleep at night when they're napping all day? Big problem in this country. And let's give the patient a little nightcap. Let's give them a glass of wine. I'm doing that for the cardiovascular benefit, but maybe they're taking straight alcohol. Who knows? Some whiskey. Boy, oh boy, this patient better not go driving. And this is the type of additive CNS depression that we see constantly. This is another big area in pharmacy, is the QT prolongation. Patients that are on multiple drugs that prolong the QT interval, putting the patient at risk for arrhythmia. And this is particularly risky in patients who already have a prolonged QT interval, patients who have afibrillation, they've had a heart attack, maybe they've got a long QT at baseline. And there are many drugs. There's a website called QT Drugs where you can look up the relative risk for QT prolongation. I use that site myself commonly. Then we've got this problem of serotonergic toxicity, and I want to give a patient that I had this past year. The patient was on a very high dose of bupropion, an activating agent. Oops, it should have been written down here. The patient was also on 60 milligrams of Prozac. We have all seen these psych medications are used in very high doses, often without a lot of evidence to support the use. And then the patient was put on linezolid for an MRSA infection in the hospital. This is Zyvox. And we see this alert pop up in the pharmacy computer. Uh-oh, watch out, you're using with other activating agents. And the pharmacist overrode the alert because she had seen it so many times. But in this case, with this drug and this drug and this drug, especially these two at high doses, this should not have been, the override key should not have been hit. And the patient started to shake in their bed. The neurologist was called because the nurse thought the patient was having a seizure. In fact, the patient was shaking because they were on so many activating agents. So we need to watch out for that. And now the topic of additive renal toxicity. I'm going to use the worst example possible. Let's say we have a patient on an aminoglycoside, such as gentamicin for a gram-negative infection. Maybe the patient also has vancomycin on board because they're trying to rule out a MRSA infection. Maybe the patient, oh no, let's give the patient also amphotericin, or what we call amphoterrible, another nephrotoxic drug. And just to totally put the patient 10 feet under, why don't we give the patient reduced renal function at baseline? And you know, you really expect that, because a patient that might need all these drugs is probably a sick, frail, elderly patient who may have reduced renal function. There goes the patient's kidneys. This I just used as a worst case scenario, but let's realize that you can just put a patient with reduced renal function on any of these drugs, maybe even aminoglycoside by itself, and damage the kidneys enough to cause renal toxicity. Now, liver toxicity is a big one in the pharmacy news the last couple of years because the FDA is considering reducing the safe dose of acetaminophen. We've seen a lot about acetaminophen in high doses, and they may think that the therapeutic doses are too high. So many clinicians are already recommending lower than 4 grams daily of acetaminophen. And then we've got the Azole Antifungals. There are many drugs here. I'm going to just try to list some of them. We've got the TNF blockers that are used for autoimmune conditions such as rheumatoid arthritis, Crohn's disease. We've got carbamazepine, hydralazine, interferons, most of the tuberculosis drugs, including INH. Most of the cholesterol drugs, like I said before, are liver toxic. Valproate and others, I'm not listing them, but you should know them. And so you can see here that you've got to monitor for liver toxicity. You need to monitor by ordering proper lab tests. The patient needs to monitor by watching for clinical signs, weakness, fatigue, pain. Now, if their skin turns yellow, their eyes turn yellow, their feces is light, their urine is dark, that patient hopefully will recognize that these are not normal colors, and they will get themselves in to a facility to be seen right away, because that, of course, is indicative of quite severe liver damage. Okay, and that finishes that topic. If you would like more, we have it. We've got our complete course textbook. It's updated every fall, so it is current for people taking their spring exams or any time the following year. It's got all the topics for the NAPLEX blueprint, and you don't need really anything else if you want just a textbook. That's our textbook. And if you need reviews of the topics in depth, like much more than I've done right here, then we've got live courses. We've got our online course you can take multiple times wherever you have your own little computer. And then we've got our popular iPhone app, and these quiz questions are available for anyone who does not have an iPhone off of our website, where you can order any of our study guides at RxPrep.com. Thanks for listening. Take good care.